You can start recording. Yeah, thank you. Thank you so
Thank
much. Yeah, good evening, every participant. I am, as introduced by Dr. Divakar, I am Saurav Shandilya. I'm in charge of academics and strategy at my Rehab Academy. My academy is one of the best platform which organizes the digital as well as physical conferences and workshop across the country. And this is one of the platform which has got awarded by leading agencies in this year. So this year was wonderful for us, and we achieved various milestones, especially in the digital webinar. So my voice is clear to every one of you, as told by Dr. Divakar. In between, I want to like if there is some disturbance, just wait for a minute. It will be connected again. And another thing is that you will be given a specific code. That code will be announced anytime during this event, which will be spread more than 2 hours probably. And this code is for your link for the certificate. That is how we will give the certificate to every participant. So hope is clear to everybody. Now, now let me start my thing. Yeah. So today's topic is differential diagnosis. Differential diagnosis is definitely, as told by Dr. Divakar, is many of the people they are lacking in physical therapy. My idea is not to encroach the like the work zone of anyone who is from the pure medical background or cardiology or anything. It is something that I want my physical therapy community to be well aware of the differential diagnosis, because once you visit the patient, once you visit, in fact, the patient with, say, for example, chronic dyspnea, or you pay, okay, say, for example, like very simple example, you visit a patient for obesity. So one person come to you and then say, sir, I want something so that like I can go for certain medical way of losing my weight, and it could be more scientific. So like they may have chronic dyspnea, definitely. So in that case, how do you proceed? So like that's what I just wanted to, and it was there in my mind since quite long. So I have prepared. Of course, this topic is too long, and then I'm sure that one day it cannot be finished, but I have concised it, and I have gone quite algorithmic way. I have tried to make it more algorithmic so that it will be it will be much visible to every one of you. Yeah. So as I told you about the certificate already, you'll be given a code anytime during the event. It will be given by Dr. Divakar, and you can just use that code so that you can get your link. So our technology is so sophisticated that it will be monitoring you, like how much you have the percentage during the event, and seeing your punctuality, as well as seeing your what we say, the interaction. They will definitely go for the certification. Okay, fine. So I would like to yeah, I would like to share my, just a minute. So yeah, yeah, fine. So this is the topic for today. Yeah, well, yes, yeah. So I'm sharing. I hope everyone has got it. Can tell me through the chat if you are able to see my screen. Yeah, able to see? Yeah, fine. Fine. In between, if you are not able to see, just let me know through your chat. Raised hand means able to see. Okay, fine. Is there any problem? Just let me know. Yeah. So differential diagnosis. Why do we need differential diagnosis? Can anyone of you can say me in the chat, why do we need differential diagnosis? What is the idea behind differential diagnosis? Why do we make differential diagnosis? Of course, to go for the concrete, like concrete part of our assessment, and then we want to go definitely for the best of our diagnosis, right? So just one sec. So I think basic rule has been given by our option. So yes, so kindly go through the basic rules. Yeah, as you are saying by the chat option, I can see a lot of people are chat giving DD helps in accuracy of treatment and okay, to make exact protocol for the treatment, very good. To confirm the exact condition by ruling out the similar diagnosis, that's the best. And one person, Dr. Modi had told definitely very good earlier. To confirm the exact condition by ruling the similar diagnosis, help diagnosis physical and mental health disorder cause similar symptoms. Well, so every one of you are aware of this. Like, why do we make the diagnosis? Well, now let us see like how like what do we do exactly in the diagnosis? I mean, like in differential diagnosis, as you every one of you are very much understood, it is distinguishing a particular disease or a condition from others which present similar clinical features, right? It is a systematic understanding of understanding the underlying condition, disease, and elimination of other potential conditions using evidences like patient symptoms and medical knowledge. So common abbreviation we use like a DDX, DDX. Well, I'm giving you an example, right? A 40-year-old man presents with acute shortness of breath. What might be the diagnosis? It could be a lot of things, right? It could be a lot of things. So it could be, in fact, it could be acute dyspnea. I mean, of course, this acute, it could be acute coronary syndrome. It could be due to some pneumonia, or it could be due to the pulmonary effusion. I mean, anything, embolism, a lot of things it can happen, right? So how do we rule out? What do we need? That is where we need a diagnostic frameworks. So that framework, you make it like what? It's a categorized list of the etiologies for a certain symptoms, physical findings, or lab test abnormality. Physical frameworks can be categorized based on the anatomical region or organ system most commonly, or physiologically mechanism. I would request every one of you to sit with the paper and pen, because a lot of things are going to be discussed in such a way that if you are very attentive, you will be loving it. And if you are not attentive, or you are losing interest, I'm telling you, you will be left behind, because it is very tricky topic. So today we'll be exploring a lot of things. So in between, if you are not attentive, the things will go away. After listening, the chief complaint, history of illness has to be documented well, of course. Then there is a key feature comes, right? Key features. How do you decide a key feature? What is key feature? Key feature is element of patient's presentation which might help to distinguish one diagnostic probability from another. A most important factor, right? A most important factor. So key feature, how do you say key feature? What do you say as a key feature? Do you have any idea about key feature? Any one of you? Please, you can just let me know about what do you know about key feature? What do you understand by key feature? Because once you know that, I'll go for further. What do you understand by key feature? Anybody? Exact indication. Yeah, two main symptoms to indicate the disorder. Okay. Key feature, it is coughing with symptoms of for at least 2 weeks. Okay. The main symptom is indicate a disorder. Well, okay, symptom of disease. Yeah, majority of you are right. But like before getting into the symptom, we can exactly think more about uh, more of. I'll actually tell you why do we say the key feature? You see, key feature here, or I can say like sorry, is this particular key feature. Suppose, say for example, we are thinking to like we say uh, a 40-year-old man who is a diabetes mellitus, of course, DM type 2, and then he has what we say hypertension also, and the meanwhile he has a problem of like got acute shortness of the breath. So in this all, what do you find as the best? You find a lot of things. So right from the 40-year-old man, it is a kind of key feature. You got my point? Right from the 40-year-old, or it is a symptom of, say, for example, like diabetes, that is also the key feature. Then it is a kind of like he had a, what we say, as I told you, that acute shortness of the breath. So, you know, like right from that, uh, just one sec, I think it is opposite. Yeah. So it is a 40-year-old man. That is also your key feature. Then he's a diabetes mellitus. He has hypertension, and then he had acute shortness of breath. But before that, you found out he had already the cardiovascular symptoms, right? He was on the predisposing risk, right? And then you go for the history of the condition. Then you go for the after history of illness, you go for the associated history. Okay, so like his personal history, his social history, like how much he smoke or the alcohol abuse, right? So all these indicate the key features, right? So these key features are particularly very important. Once you know the key features, I'm telling you, you are up the mark. Okay, so know that, know to take the key feature, right? So when you go through that, as I have written, you see, I have written here, right? Age of the patient. Then you go for the, like what we say, past history, as I told you, then onset, then duration, then recurrence of symptoms. So these all things constitute as a what we say, key feature. So once you know your key feature, you are done, right? So always remember this particular point, what I was saying, the key features. These all key features. Okay. Now, key features has one more benefit. You know what? It doesn't let you to repeat the symptoms. So you actually document. Well, so what happened here? A lot of slides I have not made it very bit colorful or something because I did not had much time. I was busy with other conferences. See, here what you do, you just ask two questions to yourself when you meet your patient. Suppose you met a patient with like obesity. You ask two questions. Who is the patient? Not the name of the patient. Say for the person Alex has come to you, it doesn't mean that Alex is the who you were meaning to, right? Now, who is the patient means what is the age, gender, past medical history, personal, family, social history. Okay, what is it? Then ask the second question is, what is the disease? Okay, who is the patient? What is the disease? These two questions. So, what is the disease is what? I'm talking about cardiovascular. Huh? So, don't mix up with your ortho and other things. It is something with the cardiovascular. So, go quite concrete about it. So, what is happening here? Onset, discrete episodes, no associated symptoms, very important. And then what happened? What could be the diagnosis? Back to square one, right? So now list your all possible diagnoses, place in order of estimated descending probability, and learn with examples. Examples like you take example in your own hospital, take any 3-4 cases, and then say, for example, I gave you 40-year-old male, right? He had a problem like this. So how it happens? How will you document? You will document as a 40-year-old male having DM, having HTN. So all these things you will be documenting in the descending, like sorry, in the past medical history, and then you will be finding what is the onset, what is the discrete episodes, and what all the associated symptoms which were not present, right? So once you are done with this, then you'll be saying it could be acute coronary symptom. I mean the syndrome, right? It could be even the other conditions like maybe example pleural effusion or anything. So you'll be probability, you will be matching it. That is something very important. So symptom wise, now here on board, what I have done, I could have done something different, but since it is a very big topic and I want to cover everything today for you for 2 hours, so what I have done, I have gone quite algorithmic. You know, algorithm, what happens nowadays, many people are familiar with algorithm because of Google, right? Anyway, so algorithm, yeah. What is algorithmic view? Algorithmic view, I have gone through the symptoms, cardinal symptoms of cardiopulmonary disorders, like main symptoms, cough, maybe your dyspnea, maybe your these all the cardinal symptoms. I have gone according to some 3, 4, 5 symptoms, and I have tried to list down how do you identify those diseases. Is this clear? Because the whole process will take more than a day if I speak. Maybe it can take about 8 to 10 hours. So I have tried to list up all the, I can say you the all possible, what we say, all symptoms which is very commonly seen in cardiovascular disorder. Okay. So all these symptoms we'll try to focus, especially we'll start with the cough, then we'll go with the hemoptysis. Okay, it will solve a lot of our problem. Then we will go for back to maybe dyspnea, very important. Okay, so these are all symptoms we'll see when it happens. Okay, say for example, I'm talking about now dyspnea. What we are going to see? We are going to see according to organ system where it can happen. Okay, and then we will see possible etiology. Okay, then we will try to make a diagnostic framework, framework. There we will design whether really it is a disease like this. Is it fair enough? You can say from the chat. This is how I have designed, quite algorithmic, because once you are in clinical practice, you may not have such time to go for the patient for whole and soul assessment. But yes, you must come back after the patient. You need to go through his history or her history and then try to find out all possible things. Maybe it may not be important for a lot of physiotherapists who will be saying, I don't need, because like in the what we say, in the hospital, they have already pre-diagnosed. Well, it is a pre-diagnosed things, that's fine. Suppose a patient, I told you earlier example only, very important example, obesity. Somebody coming to your clinic or hospital to get reduction of weight in a quite scientific way. Okay, and I can tell you the chronic dyspnea happened to them. What will you say? Is it a heart attack? No, right? You will not say like that, because you have that idea how you have to go through. Well, fine. After this, we will go with the cough. Are we ready? You can say by yes or raising hand or whatever, because I can't see a lot of chats right now. Yeah, fine. Fine. Thank you so much. So we are ready with the cough. Well, now let me check it. Yeah. Yeah. We will combine our approach to understand both acute and chronic cough in this single discussion. Best diagnostic framework of cough is a combination of anatomic region and organ system. Got it? So what I have done, I have tried to go through like what is our anatomical region. Of course, functionally the lungs, and then the whole respiratory system. I have tried to find out how to go for this anatomic region and the organ system, like the part wise, functional part wise, and where the cough comes and what it could be. So let us start with the general category. Okay, so here what I say that general category here. Okay, let me see the chat if somebody is telling. Yeah, so here in the general category, uh, I have divided in certain, like as I told you, functional activities. So first is the upper airways. Okay, here it could be 4 major etiologies. What it could be? Upper respiratory infections, maybe the common cold. Okay, upper respiratory cough syndrome, also known as postnatal drip, right? And then allergic rhinitis, very popular, hay fever, non-allergic rhinitis, and then chronic sinusitis, isn't it? These things are mostly for the upper wage, and the symptoms will be subacute to chronic. If it is not a acute allergy, then it's a subacute to chronic. Nasal congestion, rhinorrhea, sneezing, right? Sinus pressure and coarse cough. Well, and then other things would be post-viral cough and laryngeal cancer, which is quite rare. So we will not talk about this. I'm talking about this post-viral cough and these things. So what is happening right now in the world? Everybody is knowing about corona. I think it has spread everywhere, most of the countries, right? And uh, Like many people who has even the sneeze, people stay away from them the 6 feet. I mean, this is a good practice. I'm not saying that, but it is happening, right? So many people came to know about the upper respiratory tract disorder, especially the sneezing, rhinodia, and all, especially after the COVID came into picture. I believe so. Earlier, I have seen people going to office or attending classes even after they have running nose or something. But right now, if somebody has that, they take care. This is how the COVID has brought the change. True or not? This is that it has brought the change. So I will not talk about COVID because I know you people are knowing better than me, or may have attended a lot of conferences or workshop on this. So this is how the upper airways matters. Then now other functional part. I'm not talking about in general. It is a functional anatomical part. What is happening here? You see, what is happening here? It is pulmonary. We'll be talking about pulmonary. What is happening? Acute bronchitis, usually viral, isn't it? Having overlap with upper respiratory tract infection, even bacteria can cause it. Then pneumonia, bacteria, mycobacterium, and then fungal also. So you have to rule out which is that. How will you rule out? You'll go for the blood picture, specimen collection. I mean, sputum you'll be sending for the lab test, right? That is how it happens. Now, cough variant asthma, very important. Allergy mediated. It is allergy mediated. So rather than it is having a like a wheeze and any kind of dyspnea, it may not be present, but it is still the cough variant asthma we say, because it is allergy mediated. Okay, so it comes into the upper respiratory tract issues, pulmonary issues, and then you find the chronic bronchitis, pulmonary issues, very important. COPD, all the physios know better. Bronchiectasis, both causes for chronic and productive cough. Fine. Lung cancer, interstitial lung disease, aspiration, foreign body aspiration. So this is how you are different. You see, cough, you are knowing cough, but at different functional level, different type of cough will come. This is how you have to find out. Okay, if somebody is having black cough, what does it mean? He's working in the coal mines, right? Then the black cough, it could be not black, I mean, the shade will be blackish, right? Now even GI, you see, GI, gastro intestinal system, I'm talking about, very confusing to classify, very confusing. So I have not taken any headache on this. What I have done, I have tried to go for like a GERD, very important. No consensus, but still HLCR cardia, those conditions can cough, can make you cough, can make your patient cough. Gastroesophageal reflux disease, isn't it? Now, other miscellaneous causes of cough, you will be seeing like a ACE inhibitor effect, and then mitral valve pathology, rare, but it happens. And then ciliary dyskinesia. How many of you know about ciliary dyskinesia? Very important for physical therapist, I say. Ciliary dyskinetic syndrome or something. How many of you remember it? Cilia kind of structures, which actually the first or second line of defense, which propels your foreign bodies to move out of the respiratory tract. That is how the stroke happens like this, right? It goes like this, and then stroke happen like this. So ciliary dyskinesia means what? This stroke, this movement will be not possible. This movement will not be possible. So this is how we say that generally ciliary dyskinesia, we say ciliary dyskinetic syndrome. Well, because the normal stroke, what it is there with the cilia on the respiratory tract, it is not possible. Generally, the stroke goes like this. If you have forgotten, go to your textbook and then find out. Okay, then tick cough, and then of course somatic cough syndrome, psychogenic. Many people, they keep coughing, no underlying reason. You would have seen people who keep coughing, no underlying reason. It could be somatic cough syndrome. We cannot say that he's mad or something. It's not like that. It's a psychogenic also. Then tick coughing also. Tick coughing, those who have attended my workshop earlier in advanced breathing, advanced cardiopulmonary techniques, they know about it. Now, but how to diagnose the case? That is how you were knowing these kind of you have the algorithm of the cough, like at different level, different kind of cough comes. I know, but now how will you know about it? History of illness. Very simple. History of illness. You take duration, you take timing of the cough. In fact, amount of the cough also you take. Productive or non-productive cough, both very important. Presence of fever, associated symptoms. See, dyspnea, chest pain, hemoptysis, nasal congestion, or weight loss. I know every one of you know this. So if it is a simple coughing, and then when you start adding fever, then you become serious. If there is a chest pain, even more serious. If there is a dyspnea, then even more serious, right? This is how you keep adding the symptoms which is present in the patient, and it makes you serious about it, right? So this is how we actually work out with this. Well, now next part is even more interesting. When we talk about this next part, it is even more interesting. Interesting, anything I say, mainly because just one sec. Yeah, I wanted to keep my pen over here, tablet. So interesting it becomes like how much you are adding, sorry, adding symptoms. Cool, very simple. You are adding symptom, that is how it is happening. Otherwise it will not happen. Very, very simple. Okay, now you will be seeing the condition like a chronic lung disease, immunosuppression. When it can happen, maybe some of the kidney issues, or let us talk about immunosuppression in case of cancer, generalized weakness, where you can see more of cachexia. Okay, or you find something like a renal transplant, right? So anywhere where you use a lot of steroid or antimetabolite drugs, so immunosuppression cases can come. So it's very important for anyone when you are taking assessment for the cough, for diagnosing the case. Then smoking history, very, very important. Use of ACE inhibitors. I don't have much time, but I want to know, I want to tell you, every one of you, that say, for example, this is the surface of okay. Say, for example, this is the surface of alveoli. Okay. If there is a lot of parenchyma changing into fiber, how the blood will transport your oxygen? It is not possible, right? So it is very, very important to take the history of smoking. And when I'll be taking the classes on the investigations, I'll be detailing you even more. So use of SE inhibitors, as I told you, very important. It's one of the miscellaneous causes where actually you generally become more confident about it, to learn it. Yeah. So here another thing what you will be taking is vitals. Okay. When you are actually diagnosing the case of say, for example, cough, in that case vitals play always an important role. In fact, any kind of cardiovascular problem, we always say vitals are fairly important. Okay, and here the vitals is not just your temperature, pulse rate, respiratory rate. Okay, and of course BP you have to take, and then addition is SpO2, very important to take. I'll tell you how it is very important. It's very, very important, SpO2. And after that, like these vitals are very, very important. I know these things could be little bit boring for you, because you'll be saying that vitals are important. I know that, but how? In the coming slides, when I'll be detailing you with the dyspnea, how you are having an initial evaluation and how you are adding up the new diagnosis, the diseases. How you are adding up the new component, the diagnosis changes. Okay, so focused physical exam. Then of course ENT, what we say, HENT exam, head, ear, nose, throat, everything. And then pulmonary exam, very, very important. Then of course you have to find out the cardiac exam. Last time I had classes on how to find out, how to do the chest and lung assessment. That time I told the person who is sleeping like this in the semi lying position, what you have to do, you have to make the patient to see at 90-degree bending, right or left, and then you have to find the JVP, whether it is raised or not. Well, now next thing, CBC. Always remember, CBC is the first and foremost lab test for any kind of thing, and especially when you have cough, CBC is the only one which is indicated soon. And then of course chest X-ray, most of the chest X-ray to find out whether it's a productive cough, and even symptoms like dyspnea, weight loss, or maybe the kind of pain in chest or hemoptysis, especially in the elderly cases, or at risk of any sort of aspiration. If they have the history of smoking or tachypnea, very important, hypoxemia, abnormal cardiopulmonary jam, or any sort of sepsis. So in these kind of thing, it is really kind of very, very important. Yeah. So clinical suspicion. How do you make the clinical suspicion? This is the very, very important part for you to understand for the cough. I know it's something which is very kind of different for you, but again, yeah, you must understand that any sort of cough, as everyone knows now, basically, even the normal person, duration is less than 1 week or accompanied by other upper respiratory tract infection, which is the viral URI and fever in flu, influenza fever, or duration is less than 3 weeks, no other symptoms, acute bronchitis, we plan it. No, sorry, we plan it. Then, then we diagnose it. And then acute smoker or non-COPD case, what can be happen? COPD exacerbations, no doubt. And then subacute preceded by no resolved upper respiratory tract infection, but still cough is going on, then probably post-viral cough. Post-viral cough doesn't go lot easily many a times. So in the case of COVID also, you would have seen people saying that I am having still the dry cough symptoms. So generally, this is how you make the diagnosis after knowing certain certain cardinal symptoms uh, according to the organ system. Now, any kind of cough which is kind of chronic and more prominent in night, we say mostly GERD based heartburn issues. Then chronic cough with hoarseness in voice, you must refer to ENT. It could be vocal cord tumor or more of what we say inflammatory response in the vocal cord, so you must refer to ENT. Chronic non-productive triggered by more hot or cold temperature, is what we say cough variant asthma. Remember, cough variant asthma. Chronic non-productive triggered by hot or cold temperature, especially with the wheeze. Last Sunday when I had class on the how do you determine the wheeze, I think majority of you actually had joined that day, and you know how wheeze is a musical kind of high pitch sound what you hear from the lung fields, especially in the asthma. But again, it's not just asthma. It is again two types are there, very well, sibilant and sonorous. Okay, so you have to identify which is first is happening due to the spasm of the alveol, I mean the airways, and second is happening because of secretion. There is a problem. So those who have attended my like workshop class, they know very well how I have detailed with the equal point pressure. Very important concept. So whenever we have a chance, we will do that too. Yeah. So after cough, the next important part is what? Hemoptysis. And hemoptysis has been always regarded as one of the symptoms where actually we take, especially for the pulmonary, no doubt, but we need to find out how. So bleeding in the lungs, so diagnostic framework based on functional components of the lung. Try to understand, this is how I have done functional components of the lung, because from where I have learned quite one of the best algorithm. So this is how I have gone and I have prepared my slides. That is very, very less slides I have done, hardly 50 slides are there. Otherwise the things are very, very large, and I can tell you is very different. So what happened in airway? Airway is the first functional thing. If you say here, the four things could happen which can cause the hemoptysis. Either it's acute bronchitis, usually viral, as every one of you know. Then it happens the bronchiectasis. It's a permanent widening of the airways, right? Then cancer, of course. Then aspiration of foreign bodies, no doubt about it. It can also cause the like hemoptysis. Then pulmonary parenchyma. I told you it is a functional part. So second, after first, this is the second part. What happened here? TB. You would have heard bleeding comes, right? Necrotizing pneumonia or lung abscess. So last Sunday, whoever has attended, I mean, I don't want to tell anything who has not attended, but I'm just telling you, they can remember like how the sound comes from them different, right? So invasive pulmonary aspergillosis, not very important for you, and then chronic necrotizing aspergillosis, then parasitic infection also. So these things are the reason in the airway, sorry, pulmonary parenchyma tissue, where actually this could be the problem. Now pulmonary vascular tissue. Okay, so pulmonary embolism. I'm sure every one of you know pulmonary embolism, but how nice it is to represent for the hemoptysis. So you see here. So after pulmonary, what we say embolism, then there is a pulmonary AVM, arteriovenous malformation. This is very important. Those who are working in the hospital must have been knowing very detail about it. Then we have a miscellaneous cause. Miscellaneous components I have taken like a vasculitis, which is granulomatous with polyangiitis, and then of course antiglomerular basement membrane disease. What Geopasteur disease we say is not very important for you because we don't see quite common. And then impairment of hemostasis, non-spontaneous, and usually needs a trigger. So these reasons also cause hemoptysis, but you know what, this is so weak reason that it is needing a trigger. The trigger again could be, suppose somebody has a TB trigger, it could be anything, anybody has some parenchymatous. So it is a, like synergy of disorder which cause that, rather than anything which is highly serious. So how do you diagnose? Again same, any of the cardinal symptoms has to be diagnosed under 4 categories. My dear friends, please remember 4 to 5 categories. First is history of illness you have to take. Second thing, definitely take vitals. Well, then you can go for your focused physical exam. Very important, focused physical exam. How do you examine your lung? How do you examine your how do you examine your lung? How do you examine your heart? How do you apply your things? So these 4 5 things are very important. So remember, if you have a pen and paper, please write it down, these 4 5 points, especially with you. I am actually also try to write it. So these 4 5 things are particularly very important for any of the physios who are looking for the differential diagnosis. In fact, if they want to do the early, like early diagnosis or anything, so the first thing is like, of course, they have to take the PH you say, or PMH, let us say, or let us talk about history. History is very important. And after that, you have to go for the vitals. Then you have to go for focused physical examination. And then you have to go for, the key lab test. Okay, then you have to think of chest x-ray. If not resolvable, go for CT scan. So especially for pulmonary disorder, this is very important. So always remember, today's webinar or anything, or you go for the hospital, keep in the mind, I know you know assessment in a much better way. If you are an MPT student or something, you must have been knowing better than me. Those points I might miss, but you may not miss. But I will never miss the important point, because I'm a working person. I've been teaching students, so I'll not miss those points. Okay, so I'm not increasing your things, right? Tomorrow your examiner asks you, of course you saw your all detailed things, but if he asks you how do you diagnose hemoptysis, you should not confuse yourself and go through these 5 points: history, vitals, focused physical examination, key labs, and then of course if it is needed, chest x-ray, and then CT if it is needed. Well, so this is how with every symptom, keep these 5 points in mind and try to do with your paper. I'm telling you, you will be able to take easy and early assessment, and it will be very helpful for your practice. Well, this chronic, this particular thing, what we are going to try, of course, we are duration and volume of hemoptysis is very important, and the presence of dyspnea, chest pain, rash, allergy, fever, night sweat, or weight loss, very important associated symptoms, right? And then chronic lung disease, if it is there, you have to find out. If it is immunosuppression, again the renal transplant, or kind of cancer cases, or very terminal cases of cancer, what the condition they attend, kind of cachexia. Cachexia is nothing, it is extreme weakness in case of the cancer patient, right? And then smoking history, very important. All kind of pulmonary cases, we have to take history of the smoking history. Of course, the travel history, I know you can go for the detailed medical history, but not a problem. I have gone for that much, which is very, very important, especially for my practicing physical therapist, whom I want to be ready for their patient as early as they can take the assessment, and that will be very good for them, to learn about it. And then after that, vitals, very, very important, these vitals. Okay, again, remember, never ever miss your SpO2. Fine. So again, as I told you, focused physical exam here. Of course, you are not going to examine the back because it is the condition for the like your pulmonary and cardiac examination you have to do. And after that, you have to go for this lymph node examination. Why are we saying lymph node examination? Anybody can say through the chat, at least chat. Anybody can say through the chat. Why do we want lymph node examination, implant examination? I'm not able to see the chat. Not a problem. Okay, no problem. Lymph adenopathy is very, very important to examine. Very, very important, because we want to find out whether is there any infection which has caused any kind of lymph node swelling which has come into the system, right? So after that, skin examination, very, very important. Again, skin examination for rashes, petechiae, for ecchymosis, for associated telangiectasis may not be very important for physical therapist in terms of when they are looking to diagnose. But yeah, at least the rashes or any sort of petechiae you must find out on the patient's skin. So skin examination is important. And then head to toe examination in case of vasculitis or a cancer. Okay, last time I was telling you, even you can check for the sacral edema. Have anybody come with the answer? Why did I say that? If not, then at last you give me the answer. Okay, key labs, CBC, PTT, INR. You know that PTT, INR is so important. Then consider chest CT over the X-ray. Why? Because hemoptysis, again, the X-ray may not reveal all the picture, but here in the chest CT, we can find out about the underlying tissues, which is the causative, which is causing, in fact, the hemoptysis, the bleeding in the lung. Well, now next part is our key points. For you, key points are very important. Again, key points, as I'm telling you, key points are again about hemoptysis is something the most logical diagnostic work frame what I have tried to prepare for hemoptysis. Etiologies by parts of the lungs they affect, as I told you. Then acute bronchitis, bronchiectasis, cancer, and most common cause in the developed world, but TB and parasitic issues in the developing world. Every one of you know about this. And chest X-ray initially, then CT for hemoptysis, as usual, as ethics permit also. And normal chest CT does not necessarily rule out any kind of cancer in a patient with hemoptysis, particularly if there is a high risk present, such as smoking history or weight loss. So these things also keep in the mind, because only one parameters we cannot rely. We have to go for other parameters. Now, next, cardinal symptoms. I have tried to keep in among four is the chest pain. Chest pain. Base diagnostic framework is best described while taking etiologies according to the organ system. Chest pain you should see very, very with a lot of attention, because chest pain will cause various things. And at end of these symptoms, I will try to share my white paper and try to tell you, like being a physio, while seeing the spirometry case, how do you differentiate between two kind of condition, and then how do you differentiate like what is what, and how can you design your exercise based upon the findings. So today is the chest pain. What I was talking about chest pain here, I have taken the first organ system is cardiovascular system, where I have divided into certain parts, which is the pericardium, myocardium, valves. Pericardium, pericarditis, it can cause chest pain. Myocarditis, definitely, yeah. Heart failure, exacerbation, or hypertrophic cardiomyopathy, or Takotsubo cardiomyopathy, which is again kind of a bit rare. And then valves. Endocardium doesn't necessarily cause chest pain. Endocarditis does not cause pain, at least not directly. However, severe aortic stenosis can cause pain. Now, again, conduction system. I told you I'm dividing cardiovascular system in the functional component rather than going anatomical component. Rather than going to the more of part-wise anatomy, I have gone anatomy and function together, like anatomy and physiology together, so that it will be very easy for you to understand as well as to interpret in your patient. So we hear what happened when I go for this particular conduction system, you know very well conduction system of the heart is a very unique kind of system, and then you have some electricity with you, right? So conduction system, what I'm saying, you take arrhythmias, ischemia, but remember it's not lack of oxygen, but in turn more of down, more demand of oxygen. So conduction system is something when there is a tachyarrhythmia, so there is a irregular heart rate. Suppose it is going high, very high. So don't think that oxygen were not meeting the demand or it was not enough. But when heart rate is higher, so myocardium is working a lot, right? It is working extra. But for that, you don't have enough oxygen. That is the reason most of the time conduction system failure. It's not generally due to lack of oxygen. It is generally due to more demand of oxygen, which wasn't otherwise expected. Right. Now the vessels, other component vessels, functional component, acute obstruction of coronary arteries, occluded vessels with elevated troponin level. My dear friend, always remember this troponin level. I know those who works in hospital are very what we say attentive for troponin, but for everybody troponin level. If you tell your examiner when giving the practical exam, sir, yes, I will be checking the troponin level in case of acute myocardial infarction, I'm telling you, he may not ask you the second question or maybe the third question. Okay. Unstable, like together, acute myocardial infarction and unstable angina are referred as acute coronary syndrome. Remember, or anyway, you know, though may not be possible to differentiate from one another in initial hours. It is not possible to differentiate, but yes, it is. It is kind of, you know, like together acute I mean, what you say, myocardial infarction and unstable angina. Both are referred as acute coronary syndrome, ACS. Very important, right? ACS. Again, later now onward, we will be seeing more into this. Aortic dissection, rare but life-threatening. Why? Because layers of valve uh, getting separated. Okay, suppose this is a tricuspid valve. Okay, and it has a different layers. If it start getting separated because of being a sclerotic valves, then what will happen? It will not cause properly. It can cause a stroke because of the blood mismatch, right? So this is how hypertensive emergency, very important in vessels. When we talk about chest pain, hypertensive emergency can any cause hypertensive emergency. Why? Because anybody? Why? Because you know what happened, I told you earlier. So here what is happening, you have O2 demand a lot high, which is not which is causing which is not possible by the way. So what happened? Because of lack of oxygen, ischemia, right? And then ischemia cause what? Tachyarrhythmia. Then what happened? Overload. That is where it caused the pain because of the nerve fiber in the dermatome involved. Simple, right? So always make life simple, make things simple, and you are ready to hit the complicated stuff. So now here, next system I have taken, which is a kind of functional component, is a is a system I have taken is pulmonary system. Okay, and in pulmonary system again I have tried to go on more of functional components rather than going one by one to all anatomy and physiology together. I have tried to go. So here what is happening, you see, pleura, pleuritis, what you say that pleurisy also, right? Dry pleurisy and all. Then pneumothorax, pleural effusion. So these all conditions can cause pain. Of course, pleural effusion generally don't cause pain unless there is some inflammation or something. But yeah, it can. And then what happened? Airways, asthma exacerbation, airways. I'm talking about now airways. Sorry, alveoli. Now this is alveoli. alveoli. I'm talking about normal airways where it start getting divided, divided, right? So those airways in general, very well, there are two kinds of pressure also involved. Anyway, that is a different discussion. We'll discuss something later, sometimes later. So vessels, pulmonary embolism can cause, pulmonary hypertension can cause, lung cancer. I'm telling you, generally it doesn't cause pain unless it spreads. Okay. Say for example, if there is a benign tumor in case of in any lung, a focal, you can find. Last Sunday when we were discussing, we were seeing about the kind of diminished sound or kind of absent sound many a times. So focal, we were talking about focal. So those focal kind of, if that is a benign kind of thing, it may not cause chest pain. But once it is going to the local tissues, once it is crossing its bronchopulmonary segment, BPS, very well, BPS is nothing. It is a autonomic zone of lung, anything. Okay. Say for example, apical, anterior apical, and there are like 8 in left and in right. So there are, right. So what happened here, once it is crossing its bronchopulmonary zone, then it can cause pain. Okay. How it causes? Metastasis. Means it becomes cancer. Cancer, we don't say benign, right? We say malignant. Unless the malignancy comes, we don't say cancer. So this is how it you have to get very clear picture about it. Now GI also can cause pain. Even esophagus can cause pain. Okay, in esophagus, GERD, esophagitis, I have met my I have seen people who are getting pain due to GERD, and we actually were in night in confused with the, like, he had ulcer and he had pain. I'm actually drawing the scapula, both scapula from the back side, posterior side. Okay, he had pain in the night in this region, between the scapula. All of us were very, very anxious. Then when I came to know, I said, what is the breathing? He said, little difficulty in breathing. Okay, the person, he had a little difficulty in breathing, little, very little. In fact, he was, I can tell his breathing was normal, near normal, in fact. And then pain was here. Then I asked whether you have any radiation of pain. You know what? It was not present. He had, I actually found out it was a summer day, but he had no sweating in the fan, or maybe even after when we were moving for the hospital, he had no sweating. Okay. And breathing, as I told you, breathing was near normal, pattern was okay, but he was having kind of, bit gasping, not much. He had no radiation of pain, he had no sweating, and there was a focal pain. So when this was the condition, I was sure it is something else, or it may be cardiac, but let us have a check. And when we found the check, it was a gastric ulcer. Can you believe it? It was a gastric ulcer. They found out. So CBC and all key lab tests were normal. Cardiac risk factors, or we can say the cardiac enzymes, that was normal. Okay, so this is how we try to distinguish. Then we will see the stomach, even gastritis, as I told you, peptic ulcer disease, as I just described. Now rib fractures, musculoskeletal condition, it can also cause pain, I'm telling you. Then how you have to go for that? Musculoskeletal, how will you find? Rib fractures. Okay, costochondritis. So rib fractures, if you press the person, suppose I am having a rib fracture here in my third rib, and I had a RTA, somehow I got survived, but I had a fracture, hairline fracture here. So if you press here, there'll be a pain. Again, I'm telling you, chest pain, even the breathing may be diminished if I'm having a lower rib fracture, right? So Whenever I'll be breathing, you know, this pump handle movement and then bucket handle movement. If I deeply breathe, there'll be 1 point pain. Okay. But it is all about what? It is all about focal. Okay. Pain is focal, not widespread. Fair enough. You can find out costochondritis, again, focal. What you have to do for that treatment? Just I'm asking as a physiotherapist. You have to go for the manual therapy for the costochondritis. Okay, try to mobilize the bone. How to do it? That you have to find in other courses. Fine. Now, miscellaneous causes also can cause the chest pain, like severe anemia. Severe anemia, okay, and our workup will be different. So I'm not getting into the workup right now. And then herpes zoster, also known as seizures, and then acute intoxication like cocaine or amphetamines can cause the pain. Acute chest syndrome in sickle cell anemia can. And then psychiatric pain attack somatization. Don't say people, those who are complaining that chest pain are mad. No, you may not find, you may find everything normal, but it can happen. This is what the psychiatric pain attack, it happens. Okay, so this is possible. This is possible. Few characteristics of chest pain. Okay, how do you find out chest pain is something which is turning bad? So first thing, you see, you have to think exertional. Does it start or worse at exertion or relieve at rest? The second question you have to see, is it positional, worsen or improve in any particular position like sitting or lying down? Or is it a pleuritic? What happens usually occurs with the deep breathing. Pain can worsen with coughing. Is it reproducible? Where the doctor whom I learned these all things beautifully, he discovered this very thing. You may not find in many places, but he discovered, I mean, he was actually the one who taught me this new thing. Reproducible. What is a reproducible pain? Does pain produce while pressing any focal part of the chest? Okay, and I found it very, very important. Why? Because as for the any while pressing any, because it is very important for physical therapy, because it will find out the fracture of ribs or any sort of problem in the sternum plus ribs, right? It can be costochondritis, right? It could be a problem of okay, let us talk as like a very a good example of COVID, because post COVID many people they complain of the pain in the chest wall. Post COVID there is a complaint in the chest wall pain or kind of discomfort. And across the world, I actually many of the articles I read, it was the complaint. Then what do you go for? You have to go for the manipulation. So if you have a nice idea of how do you differentiate the different kind of chest pain, you find out these characteristics, very, very important for you to go ahead for better differential diagnosis. Right? Now, second is medical emergencies, which is presenting chest pain. I have gone bit detail into it. The reason behind it is important for you. Okay, so what you have to do here, you see, first is acute coronary syndrome, pulmonary embolism, pneumothorax, and aortic dissection. All of these can be differentiated considering 4 heads. I have taken the 4 heads again. Same description of chest pain, what kind of history it has, then examination, focused physical examination, and then of course investigation like chest x-ray and ECG. I will not talk more of ECG today because next week I have a class on ECG where you can join for free, no doubt, if you are a member, and then you can just find out for those 2 hours what is ECG, why the graphs are ulta or why the graphs are like this, which kind of graph denote what. I will not tell how to do ECG. I will tell you how to interpret ECG, seeing the ECG. In fact, being a physiotherapist, how can you know that? Okay. And in coming weeks, I'll be taking classes on a lot of investigation part like ABG, PFT, spirometry. So these all things will be, it is on the plan. So now, acute coronary syndrome. What do you see here? Here, it may be the mistake of my own mistake. I think I have typed it wrongly, but it is something like onset. Okay, onset over minutes. Actually, it is a minute. It is a minute. Here, substernal midline radiation down either arm or jaw, exertional, non-pleuritic. Okay, then I'm talking about acute coronary syndromes. Don't get confused with others. Past medical histories like diabetes, hypertension, hyperlipidemia, smoking history, 100% you have to take. Examination, normal examination. That is what I'm saying you. Always you will find most of the time the examination is quite normal. Then high jugular venous pressure, and then some crackles if there is a heart failure. I'll tell you in later slides how it happens. It's very easy for you to find out. And then ECG, it may have some of the ST and T changes, surprisingly unremarkable. Troponin levels, 100% you have to take, and then you have to check. I'm telling you, higher troponin, if it is there, then only ST elevation curve you can see. Otherwise, you can't see. Now, pulmonary embolism, how will you find out? Onset, seconds to minutes. Lateralizes with one side, no specific radiation, non-exertional, pleuritic, and sharp. That is the characteristic. Now, recent hospitalization or immobilization or malignancy can cause. So, being a physiotherapist, your work is to mobilize the patient. This is what I'm saying. Your work is to mobilize the patient. Okay, because immobilization can cause it. It may have a evidence of DVT, definitely, yeah. Usually normal chest X-ray, but ECG shows classic pattern. I'll tell you which pattern is that. Less common than sinus tachycardia, not very important for you. CT angiogram is suggested if D-dimer is elevated. D-dimer and all, I'll be explaining you later, not today. So this is how it actually works. And then next is aortic dissection. Here also onset is seconds to minute, substernal, midline radiation to back, non-exertional, non-pleuritic, and tearing kind of. They'll be complaining that there is some tear. Patient will be complaining you. And then hypertension, smoking, exam usually unremarkable aside vitals, but brachial BP may be unequal. That is something the like a characteristic feature here. The pain caused due to the aortic dissection may have brachial BP unequal. Okay, chest shows widened mediastinum. ECG is not specific, forget it. CT angiogram is in case of stable patient, but TEE, there is a special kind of test, TEE should be performed. Forget about this point at least. Remember the chest shows widened mediastinum, good for physical therapists to understand. But here what is important, BP may be unequal, especially the brachial BP, and then again seconds to minute, substernal, midline, radiation to back, non-exertional, non-pleuritic. Fine. And now fourth and last condition we'll see here in case of chest pain is pneumothorax. Onset over seconds to minute, lateralizes to one side, no specific radiation again, non-exertional, pleuritic, and sharp because it is belonging to lung. Now what happened? COPD and cystic fibrosis are the region which can cause, and the unilateral, diminished, absent breath sound. Last time I discussed about it. This kind of like a unilateral, diminished, absent breath sounds, unilateral hyperresonance. This kind of thing, when you find, it is a symptom of generally pneumothorax. Fine. And of course, ECG may not have any finding, but chest X-ray you will see the pneumothorax. Now, other algorithm how I have designed about the, I'm talking about the chest pain is how pericarditis. Okay, pericarditis. How will you find pericarditis? Pericarditis, pleuritic pain, is relieved by sitting up and leaning forward. Pericardial friction rub is uncommon and diffuse ST elevation. Second line is like second half of second line is not very important for you right now. I'll let you know later when I'll be taking classes on ECG. And then myocarditis, mild to moderate troponin elevation, non-exertional pain, last for hours to days. That is the myocarditis, right? And then pleuritis. Pen lateralizes to affected site and is pleuritic. Pleural friction rub is uncommon. Chest X-ray usually reveals the pleural effusion. You will find in X-ray. Then GERD, pain associated with eating, onset within minutes to hour after lying down. Even the case I was explaining you, it is something that in that day it happened like that. After the food, nice food, when he slept, he actually got that problem. Okay, next is MSK, focal chest wall tenderness on examination. Burning kind of pain is also limited to a single dermatome. Okay, so this is how you find out the musculoskeletal issues. Okay, now after knowing these algorithms, let us talk about acute dyspnea. Look, dyspnea, I could have gone a single point, but considering our physical therapist thing, because many of the dyspnea we found, we actually see in chronic cases, right? People coming to your OPD and then find dyspneic. So many of the cases we don't find them to be dyspneic, maybe like acute cases. We are not in emergency enough, so we don't see. So I have tried to give the acute dyspnea condition, also the overview, and then of course chronic dyspnea. So I'll be giving you 5 to 10 conditions about this. How will you find out? So before going into that condition, I have done this algorithm also based on the organ system and the symptoms. Okay, so so here hypoxemia. Okay, okay, hypoxemia. I have gone through the symptoms first. Hypoxemia. Pulmonary edema, cardiogenic or non-cardiogenic, both can cause hypoxemia. Okay, so it can be the reason of acute dyspnea. Then pneumonia also in some cases, pulmonary embolism 100%, COPD exacerbation has been seen, interstitial lung disease, pneumothorax, atelectasis, mucus plug. So these all are the reason, these all are the cause which causes oxygen less, and then it can cause the dyspnea, which we can get confused all the time with acute coronary syndrome, right? But it is a kind of acute dyspnea where oxygen are less due to some underlying reasons also. See the reason of pulmonary embolism, COPD, interstitial lung disease, ILD, what you say, and pneumothorax, atelectasis, mucus plug. So these all are the conditions where actually you find acute dyspnea. It can give, right? So in that later, I'll let you know this. Yeah, hypercapnia. Okay, hypercapnia also can cause pain in some of the condition, like the condition your COPD exacerbation, asthma exacerbation, and then acute neuromuscular conditions like myasthenia gravis, transverse myelitis, GB syndrome. These conditions lead to hypercapnia, but that does not cause dyspnea. That does not cause dyspnea. Okay, got my point? I think you got confused here. I will explain it again. What I'm saying you, acute neuromuscular conditions, because we physios work a lot with acute neuromuscular conditions, especially the neurophysios, isn't it? So suppose the condition called muscular dystrophy or transverse myelitis or spinal muscular atrophy, SMA, or GNI myopathy. Incidentally, I am working in almost all these cases. So what happened here? Here, hypercapnia is more. Okay. So hypercapnia is more because of this condition. That is how the dyspnea you feel. But generally, there is no dyspnea. In last part, when we will be explaining about it, I'll know how this residual volume increases, and that is how we have to categorize in these conditions. Like, yeah, these conditions are having kind of dyspnea, but actually these conditions may lead to hypercapnia, but it doesn't cause directly dyspnea. Okay, now next is acidemia. Okay, work in synergy with the hypercapnia, of course, lowers pH, Okay, what is happening? Hypercapnia, CO2 level high, it will cause what? pH decrease. Then what will happen? You know very well, metabolic acidosis. So this is the physiological function. What is the problem? Rate and depth of respiration will increase, isn't it? But beyond that, what happened? Ketoacidosis happened. Then lactoacidosis happened. So these all are causing the problem of lack of oxygen. That is how people can have dyspnea. Okay, especially acute dyspnea sometimes. But you should not be always thinking this dyspnea is always the cardiovascular cause. It can be due to these reasons. Okay, next is poor oxygen delivery, like in anemia, every one of you know. Low output heart failure, obstructive shock, especially where in massive pulmonary embolism, called tamponade and tension pneumothorax. So these things can cause oxygen reduction. That is how most of the time dyspnea happens. Well, now miscellaneous causes also you must remember. Myocardial ischemia can occur without chest pain. Upper airway obstruction due to anaphylaxis, angioderma infection, it can cause dyspnea. Anxiety, pain, it can cause dyspnea. I have seen people who say that I'm having pain and severe pain can cause dyspnea. Severe pain, in fact, can cause cardiac arrest also. You know that very well, right? So that can happen. So anxiety can cause the dyspnea again. And then of course acute dyspnea, and then upper airway obstruction due to anaphylactic reaction, some allergy. Anaphylaxis is nothing, it's just a allergic reaction, right? So this all are the reason where the acute dyspnea can happen. Okay, then how to diagnose? Again, remember 5 things, now not more than that. What is the 5 thing? I hope you remember. This is the first one, right? First one, focused medical history. Then second, vital monitoring. Third, focused physical exam. Fourth is chest x-ray, and then go for the key labs, and if it is needed, go for the bedside ultrasound, or of course ABG you have to do. You have to do ECG depending upon the demand. Okay. Diagnostic algorithm. Let us talk about diagnostic algorithm. It is very interesting. Okay. So here what is happening? Medical history, focused physical exam, vitals, and chest x-ray you have seen. You find everything okay. After that, you find what? You find here. You see, here you find focal crackles, and focal opacity on chest x-ray. Then it is a suggestion of pneumonia. Additional supportive features, it could be cough, fever, high WBC, and elevated procalcitonin. You have to send the blood and sputum culture. I mean, either you send or whatever, but this is how it can cause a dyspnea. You must understand that. So your patient who has pneumonia, it can be like this. This is the diagnostic algorithm of pneumonia, where it presents you acute dyspnea. Then, if you have a medical history, focused physical exam, vitals, and chest x-ray, and you find what? Coarse crackles, diffuse alveolar opacities on chest x-ray. What it is causing? Pulmonary edema. Then what you do? Assess presence of cardiovascular risk factors, assess jugular venous pressure, and then you find cardiac auscultation, then leg edema. These all things you have to find, and then apart from that, you can go for the ultrasound, or you can see the IVC, inferior vena cava, and left ventricular function. Then you can find the BNP, all this chemical chemistry panel you have to do, and then ECG, of course, it is the mandatory one, and then consider other features in radiology and find cardiogenic or non-cardiogenic. So it is not necessarily to be cardiogenic. It could be non-cardiogenic reason also. That is how the radiology features will tell you. Fine. Medical history, focused physical exam, and chest x-ray. In that, what you see? You are seeing you are seeing diffuse fine crackles or diffuse interstitial opacities on chest X-ray. What is that? Interstitial lung disease, because parenchyma problem, right? You have to review his medicines. Okay, forget medicines you don't want to review, forget it. You have to just see for your interest medicines, and then the most important for a physio to find out the working environment and then review the chest too. Okay, well, so sorry. Yeah. In case of pleural effusion, how do you decide? Medical history, focused physical exam, vitals, and chest X-ray. You see, these normal things you have taken into consideration. After that, what is happening in the examination? You found unilaterally decreased breathing sound, pleural effusion on chest X-ray. That is the suggestive of pleural effusion. Clear, very clear. So this is how you have to keep in the mind. Very simple. You know these things. Only thing that you have not categorized it. Medical history, focused physical exam, vitals, and chest X-ray you have seen. In this case, what is happening? You are seeing the unilaterally decreased breathing sound, pneumothorax on CXR. Definitely, it will be a pneumothorax. What is the big deal in this? So this is what is the benefit of studying very carefully. Here again, you see, in this case, when you have taken medical history, focused physical exam, vitals, and chest X-ray, then you have found what? You have found here bilaterally decreased sound, feces, and chest X-ray without any opacities. That is what is the suggestion of asthma or COPD. Now we have to differentiate between asthma and COPD. How we can do it, right? We have to find out. If you want to know about it, I'm just telling you that uh, in general we have a graph. Sorry, just a minute. So what happened here? We have a graph. Okay, so suppose this is an inspiration, then there is an expiration. Okay, this is normal. In case of, I'll tell you next week when we'll have PFT. There will be a coving. There will be a coving, means it will be a down coving, we say. That is in the COPD cases it happens. Okay, that is how we have to differentiate asthma, because many a time beta 2 antagonist which is not working on that is something COPD. We will differentiate that in coming classes nicely. Additional supportive features like non-case of asthma, COPD, patients are already asthma or COPD, hyperinflation or CXR means the chest X-ray, and hypercapnia you can find on ABG test. Next, medical history, focused physical exam, vitals, and chest X-ray. What happened here? You find low oxygen, normal lung exam, normal chest X-ray, especially in the pulmonary embolism. Then what is the problem? Problem is the pleuritic chest pain, risk factor of pulmonary embolism, signs of DVT on exam. You can go for the Doppler test, and then you can find clarity with the D-dimer and CT angiogram. Okay, so this is how it differentiates. Now the challenging one is start. Okay, just like pulmonary embolism, challenging ones start. What is the challenging one? Challenging one is something where the medical history I've taken, that's fine. Normal oxygen saturation, you find normal vitals and normal examination of the lung and the normal X-ray. Then you can go for the checking your chemistry panel. You can checking your ABG, checking your D-dimer, checking your CT angiogram. You can take the ECG. You can even check the pulsus paradoxicus. And then, of course, don't forget to take the troponin level. After taking all these, enlist and then find out what is the problem. CT angiogram will show pulmonary embolism. ECG with the ischemic changes or cardiovascular risk factors will show you acute coronary syndrome. Workup needed. Severe anemia. Anemia workup. If there is a you have found anemia, work on anemia. Then metabolic acidosis. Check lactase and ketones. Okay. Then respiratory acidosis with hypoventilation, where it can happen. Neuromuscular disorder like GB syndrome, like your transverse myelitis, like your DMD, like your cases of spinal muscular atrophy, that is the SMA. Then SS pulsus paradoxus. Then if ruled out everything, consider anxiety. Somebody asked me, anxiety is a common differential diagnosis. I said, no, it's not like that. Something that we have to find out. Yeah, additional diagnostic clues I can give you for dyspnea. If you don't want to remember all big picture, at least remember these things, my brothers, my friends. At least remember these things. What is that? How acute was onset? You have to find how acute was onset. Over a few minutes or less, it could be acute myocardial infarction, or it could be pulmonary embolism, or it could be pneumothorax, or it could be tachyarrhythmia. Okay. Now you have to find out whether a respiratory pattern was which type. Rapid and unusually shallow, that is the characteristic feature in asthma, COPD, exacerbation, and anxiety, of course. If there is a deep respiratory pattern, metabolic acidosis, because you want like that, you want, because you need rate and depth of your respiration, it will go higher. You remember pneumotaxis center, and there are a lot of story in that. Then presence or absence of hypoxemia is minimally diagnostic helpful, since most of the dyspnea cases, what happen, it can present either with or without it. So oxygen saturation is generally we don't consider a big picture here. Onset and respiratory pattern, if you know, acute dyspnea is a very easy subject for a physiotherapist, because you don't get to see a lot of cases, but when you get to see, at least you understand why it is happening. So in that case, you can approach your medical facility as early as possible for your patient. Now, chronic dyspnea. Okay, so this is the last cardinal symptoms we are taking, and after that we will be getting into one of the like a pure devoted to medicine, like something we'll go through that, like how we differentiate between FRC, RB, how we can go through. Don't ask me FRC, RB today, because today is not the subject of that, but at least I suppose that you know that those things, basic concepts clearly. And in later, I mean the next class, when we'll be talking about ECG, after the next class, whenever there is an announced date for this what we say that for our diagnostic things like ABZ or spirometry, those days we'll be seeing how better we can think about FRC, RB, and why, especially for B, it is one of the important pillar one physios to understand that. Chronic dyspnea. Chronic dyspnea again go to the system wise. Now it is a like a pulmonary, according to functional components. If it is a pleural effusion in pleura, it can cause the chronic dyspnea. If it is a COPD asthma, 100% airways, as I told you, it causes alveoli, chronic pneumonia, it can cause interstitial lung disease, very important, and then vessels, any sort of pulmonary hypertension, it can cause chronic dyspnea. Now, cardiovascular system, again, functional component I have gone through, pericardium, constructive pericarditis, or myocardium, heart failure, or valves, any sort of valvular disease, but only when it goes serious enough, it can cause the chronic dyspnea. Okay, now go to the conduction system of the heart. Conduction system, it could be bradyarrhythmias or tachyarrhythmias, and then vessels, at last the component, functional component of the of the cardiac system. That is something the coronary artery disease it can cause. Now, miscellaneous examples also can be there for the miscellaneous causes for the chronic dyspnea. That is something the anemia, moderate to severe, neuromuscular diseases, of course, kyphoscoliosis, very important for a physio, renal failure, obesity, and especially obesity with the deconditioning, because obesity with the deconditioning is something which present the cases of chronic dyspnea, to be very careful. Then how do you design again the algorithm? I told you, remember 5 things: history, focused physical exam, vitals, and of course chest x-ray in case of cardiovascular disorder, and then consider CT or CT chest or CT angiogram or your key labs or maybe the ECG, or depending upon the conditions you find. So history, here you have to see timing and precipitation of dyspnea, how it happens, how fast it is possible to happen. So here what is happening, you see, you find timing and precipitation of dyspnea, very very important. Presence of chest pain, palpitation, leg swelling, cough, hemoptysis, weight changes, these all associated symptoms, either it is there or it is not there. Symptoms are there or not there.
Excuse me, Dr. Saurav.
Yes.
Yeah, 30 minutes more left.
Yeah, yes.
Yeah.
I'm thinking that another 2-3 slides I'll be ending, and after that
Yeah. Thank you, sir.
10 minutes
So
of
just for
that will be there.
update. Thank you,
Yes,
sir.
thank you for updating. I didn't see the time. Past medical history, like your cardiovascular risk factors, and then immunosuppression. Then general medical history, of course, you'll be taking. Very important for you to take this particular thing, social history, like smoking and then drugs and alcohol abuse. You have to find out what it is, and then history, like any kind of animal allergy, or he is having an exposure of any kind of pets he has at home, and then occupation, hobbies. Why it is animal or allergy? Like I told you, even the IRD can cause the dyspnea, right? So that is how you have to go through this. Then after deciding these all algorithm, you know very well vitals you have to take, and then you have to go for the focused physical exam, right? So cardiac and pulmonary auscultation. Last Sunday, I had a discussion, a detailed discussion on this. Like I think I have sent one video also that was very informative video. Many of you would have seen that, but I didn't find any kind of this one feedback on that. JVP extremity exam, basic neuro exam, emphasis on muscle strength. So basic neuro exam, always take it in case of chronic dyspnea, the patient who visit your clinic, because many a times it is a problem of muscles, right? You have to problem of reflex, right? So all these factors unite together and it can cause the regional chronic dyspnea. Now, key labs, of course, you'll be taking CBC, BNP, and then chemistry panel. Then ECG is the 100% mandatory in this case. If you find chronic dyspnea more, consider formal echocardiogram, very, very important. Consider limited PFTs, spirometry, and history of asthma or COPD has been documented. Simple. Okay. If they tell you about the history of asthma, right? And after that, diagnostic algorithm. Come to the algorithm. Very simple. So what is happening here? As I told you earlier, we will be taking the basic initial evaluation, like being a physio. At least you should understand this very deeply. History, CABC, chest X-ray, echo, spiro. If you have taken all those things, and then you find if unilateral diffuse to percussion and decreased breathing sounds, what will happen? Pleural effusion. Last Sunday I have discussed about it. Whoever has attended, they can remember. Patient have a chronic cough with a smoking history, decreased breath sound. Again, remember, decreased breath sound, hyperinflation. The moment it is a hyperinflation, that means air trapping is there. Obstructive pattern, very important obstructive pattern. I think every one of you know this, right? Rounded shoulder, protruded, okay, rounded shoulder, protruded chin, right? Protruded chin. Remember the COPD posture, right? Posture, and then yeah, on obstructive pattern on PFT, obstructive pattern, I'll explain you when I'll be explaining more of the investigative disorder. Like as I told you, inspiration goes like this, x-axis, and then this is the y-axis. In this case, what happened? This is the normal one. Sorry, this is the normal one, and this kind of people. They'll have this, and then after that there will be a coving, means there is a gap of this. I'll explain you this thing when I'll be explaining more of. I'll explaining more of investigative disorders, investigative things for the physical, for the cardiopulmonary disorder. Then chronic cough. See, next is chronic cough, weight loss, fever, immunosuppression, focal lung findings on chest X-ray exam. Then it's the pneumonia cases most of the time. Okay, remember, significant exposure history. Person is working in a like a Florida park. In that case, or maybe coal mines, diffuse fine crackles. You find interstitial opacities on chest X-ray. I think wonderful radiology class is going on by My Rehab Academy. I don't know how many of you have joined, but it's a wonderful. I think X-ray must have been completed by today. CT and MRI for physical therapy conditions will start maybe today or maybe the next 2 Sundays. Those who wants to join can definitely contact. Then suggest interstitial lung disease, chest CT, full PFTs, DLCO, all to be considered. DLCO, again, I'll be explaining you later because this is the part of the investigation. I don't know how many of you know about it. Differential, this is something the carbon monoxide things we are taking into condition. Okay, then there is something called KCO. I'll tell you all these things. It's a carbon monoxide coefficient, diffusion coefficient. So if you find these all things, you find ILD. ILD is very, very important because you find here diffuse fine crackles, interstitial opacities on the chest X-ray. Easily it is a ILD. Now, if you find loud P2 on exam, okay, when you are examining, you find loud sound of P2. Okay, pulmonary area you find loud. Then large pulmonary arteries on chest X-ray. Large pulmonary arteries, just mark the word, high residual volume, high right ventricle pressure on echo, and then you confirm pulmonary hypertension. Simple. If sign and symptoms of heart failure, pericardial shock, pericardial calcification on chest X-ray, it is a congestive pericarditis. But if you find orthopnea, then you find weight gain, then you find elevated JVP, then diffuse coarse crackles. Again, remember last week, those who have attended, coarse crackles, symmetric leg edema, elevated BNP, cardiomegaly on chest X-ray, reduced ejection fraction on echo, then suggestive of heart failure. Heart failure does not mean stop. Heart failure means it's a failure of cardiac functions, right? So ejection fraction is very, very important factor here. Okay, so we will be talking about investigations. I'm not sure when the date will come, but investigations will have 2 Sundays discussion, detailed discussion on investigations. It is a big topic. Okay, we will be going all through the graph, everything will be going. So with this, I have finished most of things. My slides I have finished. Okay, but now here what I'll be I know your questions will be there, but before that I have something to do. Just a sec. I'll try to share. Just a sec.
Sir, anything?
Yeah, nothing. I'm just trying to share last 10 minutes. I think this is a very good discussion going on. I saw the chat. Somebody asked BNP and somebody answered also. Very good. Just a minute. I'll share you something if I can find out. Yeah. So now, being a physio, how much? No, don't thank me now, because right now we are going to we are going to describe wonderful things just now. Just wait for another 10 minutes, and then we'll have another 5-10 minutes for if you have any question or something. But just wait for 10 minutes. I'll be explaining you, being a physio, how can you diagnose the things being very simple rather than getting it complicated, and you can actually discuss with your friend, and you can be more sure about it. Seeing the PFT test, how do you describe lot of chest condition? Okay, now majority of you know about the just a minute. Yeah. So now here on board, I'll just 1 minute. I'm not able to get that. Yeah, just 1 sec. Yeah, I just wanted this one blank page. Yeah, majority of you know about how to like what is FEV, and not majority. In fact, every one of you know about it. So here, what I wanted to let you know about. Suppose uh, I hope everybody is able to see FEV1 divided by FVC, that is the forced expiratory volume in 1 second divided by forced vital capacity. Don't get confused between vital capacity and forced vital capacity, because forced vital capacity is nothing, it's just a timed vital capacity. So if it is a normal or if it is increased, okay, in that case you can suspect two conditions. Okay, either it could be restrictive lung disease, or it could be vascular problems. Okay, this you can keep in the mind. If it is normal or increased FEV1, that would be restrictive lung disease, or it could be vascular problems. Now, if you find in restrictive lung disease, suppose the FVC is low, say for example, then what it can be happening? Then that is how, whenever you will be knowing what is DLCO value, that you will like the concept DLCO value. If it is increases, what happen? If it is decreases, what happen? If it is decreasing, that means diffusion capacity has decreased. That is what we say the intraparenchymal disease conditions. Okay. When it is increases, it could be extra parenchymal. You got my point? Extra parenchymal. And extra parenchymal is something you have to think more. Reason behind it could be either neuromuscular, or it could be a chest wall problem. In either cases, you can just now decide, I mean, you can just verify it's a restrictive lung disorder, right? It's a neuromuscular disorder, or it is a what we say the chest wall issues. Okay, so now here also there are a lot of story. Neuromuscular conditions, if you see, generally it must affect the residual volume, right? Residual volume. If, and there is one more formula. Of course, I'll let you know all those when we will be discussing that. But today, at least for differential diagnosis, you should understand. If it is a normal, that's okay. You have to take one formula, RB by TLC. That is important. If RB by TLC is increased, then generally it is a myasthenia gravis. Okay, so this you should keep in the mind. This is very, very important for you. Okay, but RV and TLC's ratio in chest wall issues is generally normal. That you should keep in the mind. Okay, so this is a kind of I gave you one overview where you can actually think of doing a lot of research by yourself, and you can actually think like how do you generally work for your restrictive lung disorder, in case you want to know about what is restrictive lung disorder in terms of differential diagnosis. Okay, after that it is a very simple, just a minute, I'll erase and then I'll let you know, just 2 more minutes. Just 1 minute. I'll erase and I'll let you know. So this is the one basic feature I wanted to let you know. Now let us talk about just 2 more minutes for hyperinflation condition. What happened actually? How do you differentially diagnose? I know your chat. I'll take it. So here, let us see FEV1 divided by FVC. What is happening? If it is decreased, every one of you know it must be an obstructive problem, right? Chronic obstructive lung disease problem, it happens. Now, if there is some air trapping, what we say hyperinflation, okay, in that case, what will happen? FVC total will be 99% normal. Residual volume will increase because air trapping is there. Then TLC also you can supposed to increase. Okay, but in the case of where there is a more air trapping, in that case forced vital capacity will reduce, and then residual volume, of course, it will increase, and maybe TLC, it will be maintained. So it will confuse you many a time. So many a times of atelectasis, you get confused when you see the spirometry report. So when you decide emphysema, you will find in the report generally DLCO, which is decreased. And in opposite to that, as it is happening, the hyperinflation, what is happening in asthma, bronchial asthma, same DLCO will increase. Okay, so this is how you should understand these concepts. Most of the intraparenchymal diseases, RV, TLC, everything decreases. But in case of obstructive lung disease, because the volume, the air is it inside, so it will be increasing. Yeah, that's true. DLCO is diffusing capacity of the lungs for carbon monoxide. There is a big equation for that. Today is not the day of talking about that. So I can't let you know about the investigative part, because investigative part will take another long time. So, dear participant, this was the presentation for the day, and I have tried. Okay. DLCO we definitely see, as Dr. Gaurav is also saying, as per the demand of the lung tissues. And then DLCO has a different kind of interpretation. It is not, in general, it is very, very important, we say that. And it has a lot of importance when we will be seeing that our our investigative part will be discussing more for that. Okay, so today's session I am done from my side. Is there anything regarding the session? Please ask. Don't ask investigative part today, at least, because then it will be differently, uh, it will be a totally different thing. You can ask today's thing. It's a big topic, differential diagnosis. I have tried very hard to compress it in as less I can. I'm not sure how far I was successful doing that, but I have tried my best way to do that. Dr. Divakar, are you connected?
Yeah, participant, please unmute yourself and ask your doubts. I think some questions are there in the chat box.
Okay. Can we give percussion technique to bronchial asthma patients? And then uh, bronchial asthma patient. Okay, I have seen some questions. Okay, so bronchial asthma, you have to consider two things. Okay, there is a special type of bleeding I don't want to discuss today, because the treatment part, I told you, treatment part don't ask me today, don't ask the investigation part, ask me today's relevant topic. But still you have asked. Let me tell you, if it is an acute asthma, acute attack of asthma, if somebody in your clinic it gets, of course, you cannot think of all those things. You have to go for the relaxing position. Relaxing position of for the bronchial asthma. In case of acute exacerbation, you know very well, make patient lie down and then you have to bend the knee and then keep a pillow and make it more relaxed, right? So apart from that, for normal, this one, we definitely do that. No doubt about it. We have to find out the other factors also. It's not only one factor. Definitely we do that. And yeah, somebody asked this about AC inhibitor, whether it's related to cough. Definitely, if you AC inhibitor part, if you reduce that, it can interfere with the cough. Definitely, it can. Uh, but it is not very, since we physios don't talk more of the medicine part, so how it actually works and all, that is a different thing. But yeah, definitely it works. There is a, again, deep theory related to that. Please ask today's related to today differential diagnosis. Anyone can ask, can mute and ask. Yeah, both are different. Somebody asked bronchial asthma and bronchiectasis. As you know, bronchiectasis is generally the widening of the airways, but bronchial asthma is all about different thing. Bronchial asthma is something where the bronchospasm happens, okay, where the expiration is a problem. Air doesn't come out easily. No, Akshay, I'm not tired. Okay, well, okay, well, hypercapnia, how it can cause muscular dystrophy. Sorry, you have got wrong. I have never told hypercapnia cause muscular dystrophy. Due to muscular dystrophy, hypercapnia happens. That is what we say, that dyspnea can occur when you are doing more exercises to them. I never said that hypercapnia causes muscle dystrophy. Sorry, don't get it wrong, please. Huh? I never said that. Okay, I think sir has given certificate code to every one of you. You can just dial that code to and then send on the message to 9066990059, which is the number of, yeah, it has come on your screen. Meanwhile, everybody, please send that. Code has come. You can just see the code DD. You have to WhatsApp on 9066990059. The code will be valid, I guess, for another 1 hour, 1 hour or half an hour. I'm not sure. As early as you can send, the link will given to your mobile. You can just switch on from there. Breathing exercise to bronchial asthma if they have cough. Again, you're asking the treatment question. That's good. Definitely, you have to teach them. It depends upon whether it's an acute exacerbation of asthma. That time you have to give the relaxation exercise. There is some butico breathing and all those things you have to give with the asthma patient. But when it is a normal chronic cases of asthma, definitely you have to do it. You have to do these breathing exercises. You have to make them relax. You have to make the real question has come now. Differential diagnosis vary with obstructive and restrictive condition. Baba, I just at last I gave you a very good review of and very good nice presentation of how do you actually differentiate just seeing the spirometry. You can do that. So I think you can remember that it's very easy. In the case of restrictive lung disorder, everything looked normal, but again, RV by TLC ratio, if you take it, residual volume by total lung capacity, which is exactly the thing is like where you find it is decreased. It's a kind of restrictive lung disorder. Uh, in case of obstructive lung disorder, there is a different set of thinking, because restrictive lung disorder, it will open, the link will open at a time. If server is busy, it cannot. So restrictive lung disorder, you have to do for the spirometry, you have to go for the, and then of course code has been there on the main screen. You can see it has been shared. Just send that code to, feedback link will be given to you in the group. So that is how in obstructive you have to take the spirometry. We have to find out a different level of spirometry. Restrictive lung disorder, even we have to find out the shape of the chest that you can find on the X-ray. And then when you see the X-ray film, of course, in the case of obstructive, you find hyperinflative point. You find a lot of what we say that in case of restrictive lung disorder, you'll have a different film. And when you see basically spirometric problem, you will spirometry chart, you will have a different kind of readings for restrictive as well as for obstructive. I think at last I was writing properly on that, like how you can find out through the TB and RV. I told you initially only. Please. Yes, Galaxy J2. Sorry, I didn't know your name. Yes, gastric problem cause focal pain in mid of the back. Yes, that is true. I gave you one with the example also with one of my friend when it happened. Okay, those from other countries who have joined, whose number it is not going, try to send on the WhatsApp. I think WhatsApp it should work. If it is not working, then uh, then we'll do something different for especially joining from the different country where the code is not working. But I think on WhatsApp it should work. Okay, so that is how the obstructive and restrictive lung disorder, we have a purely spirometry where we find out. So next time when we will have investigation, I'll let you know how the spirometry curve matches differently. That is how I'll be able to let you know uh, how the coving happens, how the restrictive lung disorder decreases, how the graph get different. Okay, that is how it will. Okay, somebody asked about empyema and pleurisy. You know very well empyema is having a pus collection, right? And then pleurisy, it is not. Pleurisy is more of dry disorder of the pleura. So these all are the pleural conditions most of the time. Of course, it will have matching symptoms, but sign-wise, we can find it different. Recording and presentation, definitely it is available. You have to send tomorrow onward the request to the same number. I hope I told you, whoever has asked about the pleurisy. Sorry, empyema. Empyema is basically a collection of pus. Empyema is a collection of pus in the space between lung and then inner pleura, inner surface of chest wall. What you say, the pleural, uh, parietal pleura. That is how it differs from that. Anybody else has any question? All these are pleural conditions. Relation between blue waters being fluffered with differential diagnosis. Yeah, definitely there are some patterns which actually shows the blue blotters and pink fluffers have differential diagnosis, no doubt about it. Uh, Yes, definitely. I think in between I was explaining about the common COPD posture, right? So in that case, yeah, definitely it has blue borders and pink puffers. Whatever you know about them, that is correct. That's not a problem. Pleural, yeah, pleural disorders. I did not go much detail, but yeah, definitely you can find out these all pleural problem like pleurisy, the inflammation of pleura, especially, which gives the pain, but empyema and all those conditions where the pus comes into the picture. Then you'll have a friction rub, how you find the friction rub. I think last Sunday when I was explaining like how to listen the pulmonary friction. I mean the pleural rub, how to know about that sound, how you can actually differentiate between cardiac rub and then pleural rub, right? So these all things you have to find out. Of course, this was a small session, but I try to present almost everything. Role of physio in obstructive and restrictive lung disorder. What are you saying? You have all the roles to play to design your program. Once you know about the obstruction, once you know about the restriction, you will be designing your right from position to exercises to pulmonary rehabilitation. You will be able to do that. Yeah, myasthenia gravis. Somebody asked. Fine, respiratory compromise. Please explain. What do you want explanation? Can you be little elaborate on that? Because as I told you, these all are the neuromuscular condition where actually it does not cause any dyspnea as such, acute. But what happened? The respiratory, what we say, the more CO2, like the hypercapnia, when it happens, it actually decreases the demand. I mean, the overall oxygen. That is how they need rate and depth of oxygen, right? That is how the condition of metabolic acidosis comes. So metabolic acidosis is a physiological condition. It has to happen to increase the rate and depth of breathing, to increase the level of oxygen in the lung, in the body, in fact. So all the neuromuscular conditions, one tip I am telling you anyway, don't do, just learn the optimal level of them. Once you know the optimal level of them to do exercise, please don't cross that. I'm telling you, please don't cross that. Today's class is not for that, but still, neuromuscular disorder, I'm giving you this example. Don't make them tired. I'm telling you, if you make them tired, you are actually damaging your patient. So please don't tire anybody having a muscular dystrophy. Please don't tire anybody having a SMA, spinal muscular atrophy, or somebody having a kind of myasthenia gravis, or having a GNE myopathy. Please don't tire them. Just, I mean, it's not that they should get tired. It's something that they have done a proper sit. That's it. Don't push them for more and more and more exercise. Not good. Yeah, the link will be working. You can just go through that. Again, you are asking the same question: how hypercapnia causes muscular dystrophy? I think that you are the same person who asked earlier. I'm not sure. I never told hypercapnia causes muscular dystrophy. I said in these kind of condition, hypercapnia happens, which can reduce the normal level of oxygen in the blood, which can cause the kind of dyspnea. But hypercapnia never caused dyspnea as such. Okay. Okay. Sorry if you're not the same person, but no, hypercapnia cause muscular dystrophy as such. I never told that. It's a pure genetic disorder. There is no link of certificate. You have to message DD to the 9066990059. Those who have not received can try little 5 minutes later or something. Okay, then thank you so much, participants. Today's thing will wind up. Those who asked about blue bloater and pink bluffer, they are the real person. I mean, they know correctly. Blue bloater is something, the chronic bronchitis, and then pink bluffer is something like an emphysema condition. So both have a different thing in terms of onset as well as for the sign and symptoms. So I'll be leaving now. You can just get your certificate on the link has been given to you. Dr. Divakar?
Yes, sir. We will
Okay.
we'll wind up now.
Okay. Thank you so much. I'm
Thank you.
leaving.
Thank you. Thanks a
Thank you
lot.
so much, participants. Thank you. Thank you, sir. Thank you, sir.